Now, I'm sure when you reflect on that, the importance of those general specific questions. And I've sat through this exam many times, probably about 100 times with the Australian Medical Council people and college examiners and students. And every time the candidates ask those general questions, the diagnosis just hits them. And they pick out the key features, they know what to examine, they know what investigations to do, and they've got the diagnosis. And that's what it's all about. Then, of course, we have the management. And the first thing is to get the diagnosis. Now we're moving on to case 2, and that's of a 15-year-old adolescent who presents with a 3-day history of painful throat, malaise, and fever. And on examination, he has fever, 39 degrees Celsius, and that was the throat. You can see it's a rather dramatic looking throat when you look into it. He had a large tonsillar, posterior cervical, and submental lymph glands. Now I know you're all sitting there, and I hope you would have come up with a provisional diagnosis on that history. So we'll see how we analyse it. This is the diagnostic strategy for an acute sore throat. On probabilities, that child, when his mother came in and brought him in, I thought this child probably got viral pharyngitis. But he could have streptococcal tonsillitis, which we used to see a lot of. We don't see quite so many now, but they're around. What can't we afford to miss in this young person? Well, we can't afford to miss cancer. We can't afford to miss a blood dysplasia, because people with blood dysplasia can have a throat like that and unwell. Agranulocytosis due to drugs. So we're going to take the drug history is very important. Acute epiglottitis. We don't see them so much now, but when I was starting practice when I was at Children's Hospital, it was a terrifying illness. But now with immunisation, we don't see so many. But they can be presented with a sore throat and be very sick very quickly. And of course, we can't afford to miss in some younger people, or any people, the possibility of HIV infection. It's one of the pitfalls, of course. So the pitfalls of someone presenting with acute sore throat is Epstein-Barr mononucleosis, glandular fever. It's at the top of your list as a cause of viral pharyngitis. Sexually transmitted infections. I'm sure you know by now, as I know by now, sexually transmitted infections never surprise me. It's amazing who they bop it in and where they bop it in. So you've always got to be thinking about it. Oropharyngeal candidiasis can present like this, although they don't usually have a very painful throat, and that's associated with diabetes, of course. Thyroiditis is another cause of painful throat, not so common. Your masquerades here, to go through your list, you've got diabetes, you've got drugs, and you've got the thyroid. Is the patient prone to tell me something? This young man, most unlikely. I've had 3 children present like this with the sore throats. I don't think they're trying to tell me anything, but the provisional diagnosis, of course, was mononucleosis in them. Let's just look a bit further in this young man. He happened to see another doctor in the practice who was relatively inexperienced, and he looked at the throat, and not to be blamed, he thought this is a bacterial infection, because that's what they can look like, and he wasn't very experienced. And he diagnosed streptococcal tonsillitis just empirically. Didn't do any tests, and regarded the abdominal examination as normal, because it's important to do an abdominal examination if you suspect mononucleosis. So he gave him an astrophic gargle and prescribed oral penicillin. Now they brought him back, and this is what I saw. This is when I first saw him. He had this purplish, non-pruritic maculopapular rash. It wasn't terribly itchy. It wasn't particularly distressing, but the sight of it was quite dramatic. But from my experience, which was by 30 years at this stage, I recognised the colour of the rash, a purple hue, which is the colour of the rash, associated with mononucleosis. So I looked at his throat, it still looked the same, but its abdominal examination revealed a slight enlargement of the spleen. we've tended to go mononucleosis, and blood tests can fill in the diagnosis. So, feedback, what are the lessons to be learnt? Tonsillitis and mononucleosis is a great trap in general practice. We've all fallen for it. I've been guilty of removing the tonsils of someone who had mononucleosis. In retrospect, I found out that I thought they had bacterial infection, which was recurrent, strangely enough. Associated hepatomegaly is uncommon. Splenomegaly is more common, probably 10%. You can get a primary macular rash with glandular fever, but if you prescribe ampicillin and amoxicillin, about 20% of them will get a rash. And up to half will get it with penicillin. Of course, what we usually do is prescribe phenoxymethyl penicillin for a streptococcal infection. And quite often that's the clue, the diagnosis to come back with a rash. But please don't think the rash is synonymous with penicillin hypersensitivity. I think we are very quick to regard someone as hypersensitive to penicillin, whereas penicillin later down the track can be a life-saving drug for them. So don't be quick to label because you're giving someone with glandular fever penicillin. And as you know, the treatment of Epstein-Barr mononucleosis is very conservative. The big thing, of course, is getting the patient education leaflet and getting to tend a lifestyle with adequate rest, fluids and so forth, and they usually get better. The key investigations for a sore throat, of course, you said FBO, your mononucleosis tests, and I've listed some of them there. Your throat swab, if you suspect streptococcal infection. You often get these in institutions, someone at boarding school or someone in a prison or somewhere like that. They get a strep throat softening related to sharing of items in the bathroom, for example. It's important to do blood sugar because you don't want to be missing diabetes in the early stage. I just put a warning to beware of phospholytic glotitis. You still get it, but it's a terrifying illness. I've seen many children come in dead or almost dead from epiglottitis. Important thing if you suspect it. And these people are very toxic and they have a particular sort of drooling from their mouth and a snoring inspiratory noise. And you must not examine the throat if you suspect it because you can trigger them up into obstruction. So I hope you've learned a bit from that about how we approach it. For those of you who are watching this webinar, most of you are in the process of learning, but this is the way you learn, by exposure and in these programs, particularly with the visual programs. And there's no doubt that you'll learn a lot by experience, and you people have to get the experience, but you can use a system to bring you up to speed a lot quicker. And this is what we're trying to do by developing the diagnostic strategy models. We need to supplement with visual material. And also I'm very keen on developing a program which I call flashcards. And where you do your own cards for all the common problems and you keep revising them. You'll hear more about that later.